Thank you, Professor Wielgosz. It's a great pleasure to be here with my mentors and my friends. So we have just heard about the importance of first trimester screening for preterm preeclampsia and how to a great extent this can be prevented by the administration of aspirin. However, we still have about 25% of cases of preterm preeclampsia and more than 50% of term preeclampsia that cannot be predicted from the first trimester assessment. And in any case, unfortunately, it may take a while before the first trimester screening for preeclampsia is widely implemented. So I will now focus on the second and third trimester screening for preeclampsia, and I will discuss common management options. So what is the rationale for screening in the second and third trimester of pregnancy? So the assessment at 12 weeks aims to identify a high-risk group and hopefully prevent preeclampsia by administration of drugs like aspirin. The aim of the 22 weeks assessment is to predict who is at high risk and on the basis of such prediction, define the intensity of subsequent monitoring. And at 36 weeks is when we have to be deciding on the best time and method of delivery. So let's start from screening in the second trimester. So it should be best performed at 19 to 24 weeks, which is the time when we are routinely carrying out a scan for detection of fetal abnormalities. So 22 weeks assessment is best performed by a combination, by a quadruple test, which contains the measurement of mean arterial pressure, uterine artery pulsatility index, placental growth factor, and S-FLT1. And this is extremely good for detection of preeclampsia that requires delivery before 32 weeks, moderately good for the prediction of preeclampsia at between 32 to 37 weeks, and quite poor for detection of term preeclampsia. If we want to pick up more cases of preeclampsia at between 32 to 37 weeks, we need to screen closer to the event. And you can see here that at a detection rate of 5%, if we screen at 32 weeks, we are picking up 99% of cases of preeclampsia. And if we screen at 22 weeks, we will be only picking up about 75% of cases. Similarly, screening for term preeclampsia is substantially improved as we move from 22 to 32 to 36 weeks, and at a 10% false positive rate, we are achieving a major increase in the detection from 45 to 55 to 75%. So therefore, somebody could argue that because of the different types of preeclampsia, we should have 3 stages of screening. With 22 weeks assessment, identify a high-risk group that requires monitoring at between 24 to 31 weeks. Then again, screen everybody at 32 weeks, so identify those that require monitoring at 32 to 35 weeks, and then again, screen everybody at 36 weeks. An alternative strategy is that we propose is that screening at 22 weeks divides the population into 4 groups. A very high-risk group that is at high risk of developing preeclampsia before 28 weeks and requires monitoring at 24 to 28 weeks. Then the high-risk group that requires monitoring at 28 to 31 weeks. Intermediate risk group that is at low risk of developing preeclampsia before 32 weeks, but is at high risk of developing preeclampsia at between 32 to 36 weeks. And then the low-risk group that is extremely unlikely to develop preeclampsia before 36 weeks, but is at risk of developing term preeclampsia. The aim is to keep the very high and high-risk group on both occasions as being very, very small and contain the vast majority of preeclampsias that occur at that time. And we should aim to have the low-risk group that is as big as possible and contain as few of the cases of preterm preeclampsia as possible. So now we have accumulated data of more than 37,000 singleton pregnancies that had prospective screening for preeclampsia at 19 to 24 weeks, and we recorded maternal factors and history, measured the uterine artery pulsatility index, mean arterial pressure, and serum PLGF and fleet, one with either Roche or Thermo Fisher equipment and reagents. And in this population, the incidence of preeclampsia was 2.9%. And then we used the FMF algorithm to calculate the risk for preeclampsia before 28 weeks, before 32 weeks, and before 36 weeks. So we found that the performance of screening for preeclampsia with delivery before 28, 32, and 36 weeks at 19 to 24 weeks gestation achieved by a combination of maternal demographics and demographics characteristics and maternal history, uterine artery pulsatility index, and mean arterial pressure is substantially improved with the addition of PLGF and fleet. So all pregnant women should have assessment of risks for preeclampsia at 20 weeks gestation, and this visit can be used to define subgroups requiring additional monitoring and reassessment at 28 and 32 weeks. If the 20-week visit includes measurement of serum PLGF and fleet, in addition to UTPI-AMP, the proportion of the population requiring additional monitoring and reassessment at 28 and 32 weeks is substantially reduced. So now let's move on to prediction of term preeclampsia. And I want to start by saying that term preeclampsia is important because it's much more common than preterm preeclampsia, and about 50% of all maternal deaths associated with preeclampsia are due to term preeclampsia. However, prediction of term preeclampsia by the combination at the combined test at 12 weeks, 22 weeks, and 32 weeks is poor. Also, the prevention of preeclampsia by aspirin from 12 weeks is also poor. So I want to present you a study by the group of Professor Nicolaides and Anka Panaitescu that will be presenting soon, that included more than 13,000 singleton pregnancies. The incidence of preeclampsia in this population was about 2%. And these women had screening at 35 to 37 weeks, and the maternal factors and history, uterine artery pulsatility index, mean arterial pressure, and again, serum PLGF and fleet was recorded. So the first thing that we noted that in the pregnancies that developed preeclampsia, the MOM values of MAP, UTPI, and fleet were increased, and the MOM values of PLGF was decreased. And let's look at the results. So at the risk cutoff of 1 in 20, the proportion of the population stratified into the high-risk group was about 10% of the total. And the proportion of cases of preeclampsia contained within this high-risk group was 28%, only 28% with screening by maternal factors alone. The detection rate increased to 53% with the addition of MAP, 67% with the addition of MAP and PLGF, and it increased to 70% with the addition of MAP, PLGF, and fleet. And what I want to emphasize, the performance of screening was not improved by the addition of UTPI. So the high-risk group would, of course, require measurement of blood pressure and urine analysis on at least weekly basis. And we advised to report any signs of severe preeclampsia like epigastric pain or visual disturbances. So there are alternative strategies that merit further investigation, and this, of course, include early delivery and pharmacological interventions. So there were studies that investigated early delivery versus expectant management in the group of women with gestational hypertension or mild preeclampsia. And these studies showed that if we induce the labor at about 39 weeks, we have an improved maternal outcome. However, if we induce earlier at around 36 weeks, we have a higher rate of respiratory distress syndrome. So the conclusion was that it may be fine to induce after 38 weeks, but definitely not earlier. So the pharmacologic intervention with pravastatin was recently evaluated, was investigated by the Professor Nicolaides group. And it was found that pravastatin in women at high risk of term preeclampsia did not decrease the incidence of term preeclampsia. This was a randomized, double-blind, placebo-controlled, multi-center studies, and it has shown no improvement in the risk, in the incidence of term preeclampsia. So it seems that the best method of management at 36 weeks is again stratification of risk. So we should again divide the population into high risk, intermediate risk group, and low risk group. In the high risk group, we should consider delivery at around 37 weeks. In the intermediate risk group, delivery at 39 weeks, and the vast majority of the populations on the low risk group should be managed expectantly. Thank you.